Hello, good morning. Hello, good morning.
Good morning,
Good
sir.
morning, sir.
Good
Good morning,
Welcome
Zika.
to
Good morning, sir.
welcome to the third
Yes,
lecture.
sir.
Today we're going to look at psychopharmacology, right? And I'm going to take you a little bit back. Okay, so basically, when we are talking about psychopharmacology, we're talking about medications that are used in psychiatry, in treating psychiatry. So, in treating psychiatric conditions. So you have the idea that these medications are actually called psychotropic medications instead of saying psychiatric medications. So the real name is psychotropic medications, right? Now, before I delve into the topic itself, it's very important that we go back to the psychopharmacology. And for us, what is much important is that your foundation in pharmacology should hold. And once we are talking about psychiatry, then you have to know that we're talking about neurotransmitters, which you actually did when we were doing physiology, right? So we'll make a recap of some of the neurotransmitters you studied back in physiology 1, 2. And then also you should understand that these neurotransmitters or neurochemicals have effect directly in the parts of the brain. So with the parts of the brain, you are supposed to look at the lobes and the functions and then know exactly where these neurotransmitters can be found. Okay. So let's go back. Let's make a recap of some of the neurotransmitters that you know. So what were some of the neurotransmitters you studied back in in physiology? So let's go back quickly. Let me hear you. Yeah, I'm just asking. I'm saying that what are some of the neurotransmitters that you know? Because the understanding of the neurotransmitters is very significant when it comes to psychopharmacology. So I'm sure that you came across GABA, you came across acetylcholine, you came across dopamine, you came across serotonin, you came across norepinephrine, glutamate, endorphins, histamine, epinephrine, and non-epinephrine, all those part. So some of the hormones are actually neurotransmitters, okay? And they have their own effect. And each of the neurotransmitters have their own function. And the malfunctional effects will lead to some of the disorders like anxiety, like depression, like Alzheimer's disease, like schizophrenia, like Parkinson's disease, fibromyalgia. You have narcolepsy, you have epilepsy. Okay. So if you understand what the neurotransmitters, I mean, what their functions are, you know that if they are maladaptive function, then definitely there will be some of the signs and symptoms that will mimic that of the psychiatric disorders, right? So that's just a recap. So let's look at it. Please give me the next slide and then let's go forward. Okay, so in this particular lecture, we are going to look at the classification of psychotropic medications. How are these medications classified? And then we'll look at the common ones because you guys are nurses, you actually practice. So the common ones you guys use on your ward, or you actually meet a patient coming over to say that give me this particular injection, or a medication being written by the internal medicine specialist of the family medicine specialist. One or two of these medications may be part of what will be prescribed for any patient with either diabetes or hypertension or sickle cell or whichever patient it is, right? So we're going to look at antipsychotics. You're going to look at epileptics, antidepressants, sedatives, and hypnotics, and then mood stabilizers. And then I'm sure that will end with anticholinergic medications, right? So let's look at it. So what is psychopharmacology itself? Now, you see that with psychopharmacology is a study of the use of medications in the treatment of mental health disorders, okay, or psychiatric disorders, okay. Now, the focus is that these particular medications have the tendency to alter the brain chemistry to improve the mood, the cognitive function, the behavior, and also to alleviate psychiatric symptoms. So there are situations where the psychiatric symptoms are present, and then when you prescribe these medications, they try to handle these symptoms, okay? In other words, at the end of the day, the outcome is that you're going to have mood being stabilized, you have memory and learning being stabilized, focus there, orientation being good, behavior in the sense that the patient will no longer be restless or agitated. Rather, the patient will be cooperative, calm, and then will be quite friendly, right? Okay, next. So the classification, how are these medications classified? So, I mentioned antipsychotics for you. I mentioned antidepressants and all that. So first of all, we know that the classification comes from the conditions. So when you say depression, then you associate it to the treatment as antidepressants, right? But in some way, apart from classifying them based on their purposes, in other advanced studies, they are saying that you can classify them based on their receptor functions. Okay. So, for example, you have antipsychotic medication, the atypical antipsychotic medications that will work on dopamine. And then, secondly, it also work on serotonin at the same time. So, if you take a drug like olanzapine, we'll actually get into that. If you take a drug like olanzapine, even though it's an antipsychotic, at the same time, it's a mood stabilizer. And the receptors are actually different in terms of the functioning. So some of the classifications may differ in terms of the receptors and then the function of the receptors and also the neurotransmitters that are affected. With the neurotransmitters that are affected, you look at it in terms of the purpose and also the side effects, what you call the off-label use can also be prescribed. So, for example, if you take chlorpromazine like this, or for example, chlorpromazine is an antipsychotic, but at the same time, it's used to treat hiccups. Why? Because of how the side effects actually work, right? Or if you take imipramine, the side effect is retention of urine. Meanwhile, it's used to treat kids with bedwetting problems, right? So that's just for the classification. So we'll start with antipsychotic medications. The word there is antipsychotic, which means that it's against psychosis. And we are quite sure and aware that when it comes to psychosis, we are talking about hallucination, illusions, we are talking about delusions, okay, restlessness, agitation, okay, with poor insight, okay, on the part of the patient. So the essence of this medication is to make sure that it reduces the psychotic symptoms. And then at the end of the day, it will also end up alleviating the symptoms, okay, totally. So let's look at the function or the mechanism. So anytime we prescribe any of the antipsychotic medication, what they do is that they actually block the dopamine receptors, okay? Dopamine receptors. Specifically, dopamine D2, that is a deep D2, because dopamine, we have one up to about 5. Okay, we have got dopamine 1, dopamine 2, dopamine 3, dopamine 4, dopamine 5. But specifically for antipsychotic medications, they target dopamine 2 because that is more responsible for movement, reward, and then pleasure. Okay, so the antipsychotic medication actually targets the D2 receptor and they block that receptor so that you will not have enough dopamine being transmitted to the postsynaptic clefts, okay? Now, we have two types. We have the first generation and the second generation. In fact, we even have the third generation. But with the first generation is what back in NTC, we were mentioning these things, like the haloperidol, chlorpromazine, stelazine, fluphenazine decanoate, okay? And all those examples, they are the first generation. The first generation often poses a lot of side effects, even though they have their own therapeutic effects. So because of that, there was an invention in a particular time where they brought in the second generation medication. And the second generation are known as atypical antipsychotic medications. An example includes olanzapine, quetiapine, and then risperidone. So let's take chlorpromazine for example. So chlorpromazine is a typical antipsychotic, okay? First to be invented, though, it's also a tranquilizer, okay, which means that it can calm the patient down. The treatment or their function or the indications include they treat psychosis and aggression, uncontrolled behavior. And when it comes to off-label, they are used for intractable hiccups and also has a hypnotic effect. Okay, so it has, I said it's used to treat psychosis, aggression, and uncontrolled behavior. So you realize that what you guys call lagatel, I'm very sure that when patients come to your ER or they are on the ward and they are aggressive, you give chlorpromazine, right? Now, chlorpromazine often comes in 50 and 100, right? So the maximum dose can be 600 milligram, okay, in divided doses. So you can do 200 TDS for when you are giving it IM. The challenge is that we do not give chlorpromazine IV. This is because it can lead to hypotension. So you should not, in your practice, serve chlorpromazine as IV medication because it can lead to hypotension. And most of the time, when patient comes and they are aggressive, you realize that we do the 200 milligram start or 150 milligram start IM, and then we add the adjunct medication, which is IV diazepam, which is about 20 milligram. The moment you sedate the patient or you tranquilize the patient, it is very important that you start monitoring the BP. Just as I told you, chlorpromazine has a tendency to cause hypotension. So it's very important that you monitor that particular patient throughout the course of the sedation or the tranquilizing period, right? Now, somebody may ask that why is it used as an off-label? So what happens is that because chlorpromazine is capable of blocking the dopamine receptor, at the same time, some of these receptors are found in the hypothalamus, okay? And once it's found in the hypothalamus, the effect by inhibiting the D2 receptors, okay, gives it that opportunity to suppress the cause reflex. The same effect is that by extension, dopamine, the drug is able to also touch on the GABA. And you know that GABA is an inhibitor. So one way or the other, it enhances the effect of the GABA. And then it will end up suppressing the reflex when it comes to the hiccups. Thirdly, you can also explain it in terms of their anticholinergic effect, where they reduce the hiccups frequency. Okay, so that is how come it's used as off-label. Off-label means that chlorpromazine, that is not the indication. That's not the reason why it was made. But some studies have found that when it was used in patients who have intractable hiccups, that effect came about. So people start using it as an off-label medication. So that is it. Now, haloperidol, which is classified under butyrophenols, similar in function with chlorpromazine. However, their chemical formulas are different. Okay, so when it comes to haloperidol, the maximum dose that can be given is 20 milligram. However, the minimum dose is 5. In therapeutic doses, we can give 5 milligram at night. But if a patient comes in agitated or restless, you can start with 5 milligram. You can give 5 milligram start, or you do 5 milligram BD. Okay, by the 5 milligram start, not 10. This is because of the extrapyramidal side effects that both medications can give. So in current practice, it is more prudent to give haloperidol instead of the chlorpromazine because in chlorpromazine you are giving a large dose. We can have a huge effect, okay, in terms of the side effect and in terms of the physiological response, in terms of the cardiac output. So it is people or research work is telling us that first start with haloperidol 5 milligram. Okay, if haloperidol is absent, you can go ahead and do chlorpromazine. Okay. But oftentimes we start with 5 milligram haloperidol first, and then subsequently after 12 hours, you can repeat the other 5 milligram. Now, the indications include you have agitated depression, hyperactive behavior in dementia, and then tics. Okay, and remember these two medications, both chlorpromazine and haloperidol, can also be given orally. So we have the tablet form, right? With the haloperidol, we still have 5 milligram and we have 10 milligram only. With chlorpromazine, we have 50 milligram, 25, and then we also have 100 milligram as a tablet. And as I told you, the maximum dose for chlorpromazine is 600 milligram, which can also be divided into TID, where you can give 200, 200, 200, right? Now, haloperidol maximum dose is 20. You don't exceed it because of the side effect, right? Okay. Now, the extrapyramidal side effect, let's look at it quickly. So the extrapyramidal side effects is different from normal side effects of medications. Normal side effects of medications can include vomiting, nausea, lightheadedness, dizziness, okay, frequency of urine or feeling that you want to urinate, okay, or feeling having an apprehensive feelings or experiences and all that. But when we say extrapyramidal side effect, it means that there's an adverse side effect, and this comes about as a result of too much blocking of the dopamine receptor, especially the D2. So if you are giving a patient chlorpromazine and you are giving it in maximum dose, after some days or after some weeks, the patient will come in with extrapyramidal side effect. We have also observed on the ward that when we are sedating the patient and we give chlorpromazine 200 milligram and then we repeat it in the evening and we repeat it the next day. So it's like you're giving BD times 48 hours. Sometimes by the 72 hour, the patient might be experiencing the side effects, the extrapyramidal side effects. So I want to take you through extrapyramidal side effect quickly. So you have akathisia, okay, which comes in as a compulsive means for the patient to move. So when we say akathisia, it means that the patient becomes restless. The feeling comes as in he has to move his body up and down, and sometimes they begin to walk about or move in a rocking motion. So that's akathisia. We also have acute dystonic reaction, and that one comes with a lot of symptoms, a lot of signs. For example, we have opisthotonous oculogeric crisis. You have torticollis, which is the turning of the neck to one side. You have got drooling, where you have a lot of salivation coming up, or hypersalivation. You also have tongue darting, where the tongue actually pulls out from the mouth of the patient, hanging out, and he cannot swallow back again. Right. So this one characterizes acute dystonic reaction. So if you are in the emergency and the patient is brought in, whereas you realize that the eye is turned upside down and you are only seeing the sclera, you're not seeing the pupil, right? Please ask the patient whether he's on the first antipsychotic medication or the first generation, whether the person is on haloperidol or whether the person is on chlorpromazine, because they cause that. Secondly, if you realize that the tongue, okay, protrudes out and it cannot go back again, and the person is salivating, you also need to ask the same question. Thirdly, if the neck is twisted to one side and the patient cannot bring it back to this original point, that is what we call torticollis. And that is also one side effect of the first generation antipsychotic medications. Also, the person can have tremors of the hands, right? And then the last one can be opisthotonous, okay, which normally is seen in tetanus, or you have it in migraine. People see it sorry, I said migraine. You see it in tetanus, yeah, particularly tetanus, not migraine. In tetanus, people normally have that opisthotonous position. So normally find that in children. So that is for the acute dystonic reaction. So I've mentioned two extrapyramidal side effects, akathisia and acute dystonia. The third one is what we had there. That is the Parkinsonic symptoms. It is not Parkinsonism as in Parkinsonic Parkinsonia disease, okay, in old age that you find. This one is Parkinsonism. It means that it is the symptoms that is mimicking that of the disease, but that is not the disease itself. So with Parkinsonism, you are going to see signs like rigidity, tremors, okay, imbalanced gait, okay. And normally what we do is that you can use the anticholinergic medications like cogentin to treat. Cogentin comes in 2 milligram. We use that to treat, or you use the amantadine. Amantadine reverses the overload of the blockage that is coming from the receptor. Okay, it reverses the receptor blockage. So you can use amantadine, about 100 milligram or 400 milligram. You can just prescribe that. So the next one is tardive dyskinesia. And with tardive dyskinesia, it's an irreversible reaction when it comes to antipsychotics, and it can take place after days. Sometimes if you have a person who is a known mental health service user, a schizophrenic, a person with schizophrenia who has been on the medications for a long time, the first generation for a long time, normally when they come, when you assess them, you will see that they have this facial grimacing, they have got lip smacking, they have got blinking of their eye, okay? And then sometimes there's a tongue movement in their mouth. And then you see the lower face tremors or movement, or the movement of the trunk. Normally, we find that in persons who have been on the medications for a long time. And normally, when it happened that way, we are not able to treat it back because it's irreversible. The person has been on the medication for years. And so those are the signs you're going to see. Okay, so that's what we call the tardive dyskinesia. And then the last one is neuroleptic malignant syndrome. Now, this particular part of the extrapyramidal side effect is what you actually need to pay attention to. When any patient of ours is on the third generation antipsychotics, right? Sometimes when you start giving the medication, especially when you're sedating on the ward or you're tranquilizing on the ward, and you prescribe haloperidol 5 milligram in the morning, like BD times 48 hours or 72 hours. While you give those injections, sometimes after the 72 hours or within the 72 hours, you realize that this particular patient has the temperature rising. So that's what we call the hypothermia. You have it rising. Mostly it's recorded as 38 and above. Okay, so that's the first sign you're going to see. The second time you're going to see is that the patient becomes rigid, and sometimes they have their mental state changing. Patients can also have leukocytosis. It means that you have to do a full blood count to see that there's a leukocytosis, okay, when it comes to the WBC. And also, when you take a sample to the lab to look out for the creatine phosphate kinase, you realize that it's also high. Remember, this phosphate kinase is responsible when it comes to cardiac function. Some are also found in other parts of the body, especially the kidney. So you need to know whether these enzymes are breaking in certain important organs, like within the cardiac muscles and then also within the kidney muscles. If it's elevated, it means that that person is having neuroleptic malignant syndrome. But as a matter of fact, because you cannot go ahead and make the prescription for these particular lab works to be done, the first thing you should think about is to think about the temperature rising. Once the person has been given chlorpromazine injection within the first 48 hours and you see that there's an elevation in the temperature and also there's a mental change, immediately you have to alarm or inform the physician specialist. And sometimes the physicians are not actually aware of it. So what they do is that they rather take blood for CS so that they culture. Some people start giving antibiotics. They come to give paracetamol IV, and then they run the WBC, but they don't really look out for the leukocytosis. They rather look out for the neutrophils going up. And normally you don't really find it. It becomes actually normal. So what happened is that they may treat it like it's an infection, but which is not. I'm telling you because I've seen it being practiced several times, that instead of looking at it through the eyes of the first generation, causing that, the physician end up treating the patient as if the patient has an infection, which is actually wrong. Now, the mode of treatment is that the moment you see that there's an elevation in the temperature and the mental changes, if the physician goes ahead to take biochemistry for us to look at the elevated creatine phosphate kinase. If it is elevated, it means that this patient meets the criteria for neuroleptic malignant syndrome. Hence, what we can do is to stop giving the chlorpromazine or the haloperidol immediately, you give IV normal saline about 1 liter and then monitor the temperature of the patient throughout. Sometimes we go by 2 liters. At the end of the day, you realize that the temperature is dropping without any intervention from antibiotics, right? Okay, let's go to the next slide. So with the first generation, all what we have mentioned are orals and then IM, right? But we have, which are short acting, okay? So the one that we give through IM on the ward immediately, and then also the oral that we give, those are short acting. But when it comes to the long acting, you have haloperidol decanate. So you can see it over there. Those of you who find yourself at the OPD or the ward or maybe ER, you realize that there are patients that comes in with this particular drug. And this is different from plain haloperidol. With a plain haloperidol, you see it as in the soluble form, okay? And it is watery, soluble form, and it is clear, right? But when it comes to the haloperidol decanate, this is the long acting. The long acting is given as a first shot, and the next time you give this particular medication has to be in 2 weeks or in a month. So this is a monthly medication or a fortnightly medication that is given. Most of the time when we indicate haloperidol decanate and they go to the pharmacy, the pharmacist may not actually look at it as the long acting one. They rather prescribe or they rather serve the plain one. Okay, the plain one is known as haloperidol hydrochloride, not the decanate. The decanate is the long acting, and normally it's in a fat soluble form. Okay, a fat soluble form, and it's given as a depot. So you break it, it comes in 1 ml. You break it and then you give it on the shoulder or at the back. And just as I just indicated, that you can give it fortnightly or 1 month. So in case these medications are prescribed, kindly know that there's a difference between the plain haloperidol, which is known as the haloperidol hydrochloride, okay? And normally that one comes even in 2 ml. And it is plain. But when haloperidol decanate is served, it comes in an oily form, right? And it is 1 ml. And normally it's in this particular ampoule. So when it comes, you just break it and serve it. You can either give it as a subcut or you give it as IM, right? And not IV. So that is it for the first generation. So apart from haloperidol decanate, we also have fluphenazine decanate and fluphenazine enantate. That can also be given as a long acting, right? Next. Okay. So apart from the first generation, which we have mentioned, I've given you examples like haloperidol and then chlorpromazine. We also have the second generation. So the second generation, I've given you a typical example like olanzapine, risperidone, and quetiapine. Okay. Now, the difference is that the first generation, even though it helps to alleviate the psychotic symptoms, they also pose the extrapyramidal side effects. Now, with the second generation, they do not produce any extrapyramidal side effects. Okay, typical examples I've mentioned already. So I'm saying that with the second generation, they also act as a mood stabilizer, not only as antipsychotic medications, they can also help stabilize the mood of patients. And then they also have limited extrapyramidal side effects. Their problem when it's being served continuously or used prolongedly, what happens is that it leads to type 2 diabetes and it can also lead to weight gain. The question is that how does this come about? So in as much as we are serving the medications to block dopamine receptor 2, by extension, these medications can also affect histamine, right? The H1 histamine, okay? And we know that histamine is also responsible as a motivation and for appetite. So once it affects these histamine, people begin to eat a lot. You hear the patient say that anytime you put me on olanzapine, I eat a lot. And they bloat, they put on weight because all the time they are hungry and they won't eat. Secondly, it leads to type 2 diabetes simply because it rather brings about insulin resistance, okay, in the patient. And then people gain weight in addition because of the adipocyte dysfunction. Okay, it alters lipid metabolism and storage. And so because of that, it may end up making the patient put on weight. So any patient who is on second generation antipsychotic, the first thing we do is that, or when we intend to put the patient on that, we do the baseline screening, is to look out for the lipid profile test of the person. And also sometimes we just observe. For example, if someone comes in and the person is obese, okay, obese 1, we just look at it to say that there's a tendency of this person putting on much weight. And we don't want any hyperlipidemia leading to any other cardiovascular problems. So by observation, looking at the weight of the patient, and also if the person is at risk of diabetes or already hypertensive, there's always an important way of checking the baseline RBS to know whether this patient has the sugar controlled and also the weight. Okay, and also look out for the risk factors because it's very important. And that informs whether we should go with the first generation or the second generation, right? Okay, let's go to the next one. So the second generation also has a long acting, and it comes with examples are paliperidone. Another one is risperidone consta. Okay, these are the two common ones used in Ghana currently, or what we call the Inviga. The Inviga is very expensive. It costs between 2,000 to 2,500. Some people sell it for 1,800. It's also one shot. It's given monthly, right? And risperidone consta comes in various milligrams. We have 150, 100, 75, and then 50. Now, some people prefer this because it has less adverse side effects compared to the first generation, like the haloperidol decanate, right? So this is much expensive. This is quite costly. It's as I said, it's 1,800 to 2,500. But the haloperidol decanate is about 100 Ghana cedis, which is quite affordable, right? Okay, let's look at the next one. Any question before I move to antidepressants?
Yes, sir.
Yeah, go ahead. Go ahead. Kindly go ahead.
Please, I want to ask. Sometimes with the haloperidol, sometimes I've seen some people, because the decanate, I think it's expensive, and sometimes even getting it becomes a problem. I see some people sometimes use the other one with the plain one, which is a short-acting one, and still be giving it monthly. And I'm asking, is that one right? And does it work?
No, it doesn't work. It doesn't work. Remember that the reason why we choose the long acting is the word is long acting, and it's an oily based form. So it will be released into the blood almost every day. Okay. Now, the plain one is metabolized quickly. I mean, the half-life is about 6 to 12 hours and it's out of the system. So you cannot compare that. More so, the effect is quick. So if you give a short-acting one, the effect is quick in terms of the extra parameter side effect compared to the long one, which will take time. You get it? So you cannot compare the two. So even though they may be thinking about pricing or affordability, it is not prudent. I mean, therapeutically to choose between the two, saying that you want to use the plain one to replace that of the long-acting one. So that's a wrong practice. Do you get me now?
Yes, sir. Please, thank you.
Okay. Any other question? Okay, so someone they asked,
yes,
Priscilla, I'll attend to you. Theophilus, Theophilus, please, anytime you send me or you write anything in the chat, add your campus, whether you're coming from Kumasi or Da, whichever way, okay? Very important, so that you add that, then I know where you're coming from. So Theophilus Opon, right? is saying that why do they give them the haloperidol depot when they are discharged? Okay, so what happened is that some patients have history of poor adherence to the medications. So normally when you are about discharging them, we decide to put them on that because as they go home, they may forget to take their medications. And sometimes it's not just giving the haloperidol depot alone. We also add tablets to it. Okay. The tablets are given. They are added to the depot. But we are saying that in case the person forgets to take the medications, the tablet ones, the depot is in to kick the effect. And moreover, too, the second aspect is that you may want to give haloperidol tablets, okay, in a high dose. However, if you are supposed to take it orally in a high dose, it's going to bring about extrapyramidal side effect. So at the discretion of the clinician, he will decide to say that, okay, in order for us to maintain the peak, the therapeutic peak, let's give the oral, then we are boosting it with the injectables, right? So that is why a physician may have the choice to make that decision, right? Joe, I hope I able to answer you. Okay, Dinah from Oda Sender is saying that, is there any instance where the short acting can be given start, then continue with the long acting? Dinah, yes. This is because the short acting that you are given, you want an immediate effect, maybe to tranquilize the patient, to sedate the patient, to make the patient sleep, right? But the long acting, as I just mentioned, it doesn't have a direct effect or a quick response. It takes time. Okay, so you can actually give the two. It's not going to have any. It's not going to bring about any extra pyramidal side effect. Okay. Okay, so back to you, Priscilla.
Okay, thank you, sir. Please, I want to know about the NMS, the neurologic malignant syndrome. So when you give the first generation medication, how long does it take for that signs, the side effects, which is the NMS, to show in the patient? That's my first question. And
Please,
yeah,
no, go
so
ahead.
the answer to the first question will lead me to the second question. I read somewhere, okay, I read
Okay.
somewhere about the NMS that patients who takes antipsychotic before surgery, 24 to 72 hours post-op, the patient is likely to get NMS. So I want to know if the antipsychotics have something to do with anesthesia, that a patient after surgery 24 to 70 hours, 72 hours is likely to get the NMS. So I'm quite confused with that. That is why I said, how long does it take for the patient on antipsychotic to get this NMS?
Okay, so let's construct that understanding over there, right? So first of all, with NMS, one of the things you should know is that you want to know whether the patient is antipsychotic naive. When we say antipsychotic naive, it means that he has never taken any antipsychotic medications before. Because if right now, Priscilla, I give you haloperidol injection, compared to someone who has already been on haloperidol tablets before, the two of you are going to respond differently. There's a tendency that you can have a reaction and that person will not. So first of all, we take into consideration whether the person is antipsychotic naive. That can bring about NMS. Secondly, we also think about the dose that we are serving. So for example, just one shot of haloperidol 5 or 10 milligram is not going to bring about NMS quickly. And remember, everybody's body responds differently when it comes to how they metabolize or break down drugs. Okay, so for my observation, okay, we realize that when we give it within the first 24 hours, we may not see any severe changes in terms of the temperature. I always tell you that it starts with temperature rising first, right? So the typical sign is a temperature that you need to see. So within the first 24 hours, depending on the dose, if you start with 5.5, people are not going to respond. They are not going to see the NMS. But if you continue later, you realize that NMS, there's a tendency for you to see an NMS developing. So depending on the dose, but on average, I could say that within the first 48 hours, there's a tendency for a patient to develop NMS. And I just mentioned that it starts with temperature, right? So these are the two reasons as to whether a patient is going to theater. The question is that why would you give any antipsychotic when the patient is going to a theater? So I really can't have you relating it to theater. So I'm a little bit quite confused about you bringing in theater, because are you referring to one of our patients being prepared for theater, and then it's like we are giving antipsychotic medications first to tranquilize the patient and prepare him for the theater? If you can elaborate on that, I think I'll be able to take it from that point.
Okay, sir. So the article was NMS being as a sign, like when you give the patient antipsychotic. Let's say this patient is on antipsychotic, like that's his med. Then before surgery, you serve his medication, the normal meds. Let's say hours before the nail pills. Okay, so if you give those medication, there is a high chance of the patient having this NMS 24 to 72 hours after the surgery. So that was what the article was saying. It says that it's called the depot antipsychotic, something like that. The depot antipsychotic. So I was a bit confused. And in addition to that,
Hold on. You said the article says that when you give take it from there.
So it's like, it says that it's called a depot antipsychotic.
Okay.
And if I remember, it was kind of saying that's when you give antipsychotic before surgery, NMS can develop 24 to 72 hours. That is if the patient has these antipsychotics, like that is the patient's medication. Let's say he's a patient on antipsychotic, and the normal medications the patient takes, you serve, let's say a night before the surgery, you give those medication, there is a high chance of the patient having NMS 24 to 72 hours after the surgery. And in addition to that, they even said that a patient with history, like let's say family history of NMS, when the patient,
there's a likely,
yeah.
So that's good. You're beginning to read psychiatry. That's interesting. Thank you for that contribution, right? I think somebody else wants to say something. Theophilus.
Hello, sir.
Yeah?
This is Theophilus from Kumasi campus.
Let me hear you.
Sir, I mostly take care of psychiatry patients at the emergency unit.
Oh,
and what I've realized is we normally give haloperidol 5 milligram, promethazine 50 milligram, and then diazepam 20 milligram as start doses. The other time I gave, and then my in charge was a bit angry with me. He said I give the patient modified psychotic medication. So I was like, I didn't understand what he was trying to say. But the patient was very aggressive. So apart from giving the medication, we mechanically restrained him and then kept him silent for like the whole shift before I left for my house.
You give
haloperidol 5 milligram plain, promethazine 50 milligram. Yes.
And then you give promethazine 50 milligram.
Yes, 50 milligram, and then 20 milligram of diazepam.
Oh, that's a lot. That's a lot. So what you could have done was this. You could have done the first, you could have done 50 milligram of promethazine and just diazepam. Or you could have gone in for 5 milligram of haloperidol, then diazepam only.
Oh, okay.
Yeah,
because the patient was, he came in with paranoid schizophrenia.
Yeah.
So he was very aggressive on that day.
Yeah. Yes, but this is a caution. That's why we are studying this. Thank you for bringing this out. This is almost like a case study for you. So what happened is that once you want to tranquilize the patient, you also want to think about the side effect or the adverse side effect, because you are focusing on the therapeutic and you want to shut it. You want to shut the patient down quickly. However, there can be repercussions, okay, because you are trying to give all these medications. Now, this particular medication that you just, or the formula that you just, or the concoction that you put together, it would have been good for somebody who is a known substance user who actually comes in that way. Do you get me?
Okay.
Yeah, but you are using the same path. So what happened is that when you want to tranquilize or sedate a patient, why do you use the diazepam? Diazepam has a different pathway in terms of their receptor. Do you understand me?
Okay.
So that's a benzodiazepam, isn't it?
Yes.
That's a different receptor that is going to lead to a sedation. Now, at the same time, you want to use a different receptor. So this time you're using a dopamine receptor at the same time to bring about a sedation or to tranquilize a patient, making it two different receptors. So that is why we said at the end of the day, they act as an adjunct, okay, to bring about the effect. But when you give promethazine has the same chemical compounds like that of the chlorpromazine.
Oh, okay.
So you are giving two first antipsychotic medications indirectly because you are combining haloperidol and giving chlorpromazine at the same time. But this time you are seeing it as promethazine.
Oh, okay.
Because they are all under phenothiazines. Chlorpromazine and promethazine are under the phenothiazines. You get it, but by composition, promethazine is also works on the D2 at the same time, and then it has other properties, right?
Okay, sir.
So she's telling you that, listen, don't give these two at the same time. Choose one. So you realize that if you were supposed to give the 5 milligram first, together with the diazepam, after 3 hours, when the patient is still not relaxed, okay, you can go ahead and give your promethazine. But always make sure that you're still monitoring the blood pressure, right?
Okay, sir.
Thank you so much for bringing this up.
Thank you.
Can I have any other question? Because you guys have practiced it, please say it so that you don't kill our patients.
Hello, sir.
Yeah, talk to me.
So with this sedative distance, we had a client. We started with the chlorpromazine. There was a serious aggression and other abnormal behavior. So we started with the chlorpromazine IM, the 100 or so, then 20 milligram of diazepam in infusion. All went. So this client was not sleeping. Went on. Later, when we gave is it midazolam? Yeah. And that one, so it was like, but that one helped. But later, the BP started dropping and quickly we were able to give normal saline to help manage the BP. But later on, with that, she was able to sleep. And with time, the person woke up later and everything was okay. And at least we achieved something. So I want to find out. There are certain clients, and this has happened to me about not just once. Sometimes you give all these diazepams, chlorpromazine, but the sedative effects will not be coming. Is it right to be giving midazolam at the same time? At the same time, maybe be checking your vital signs and working on it. Is that appropriate?
So I don't want us to talk about midazolam at all. Okay.
Okay.
So let's take them out. It's not part of our protocol for tranquilizing the patient. So let's slide that out, right? But Sami, you said something that is quite profound, and I think all of us need to pay attention to that. You mentioned the fact that sometimes you are giving a lot of medications, but the patient is still not sleeping, isn't it? Isn't it, Sami? Good. So what happened is that, please, there are these patients that you have to consider. First of all, so let me just explain this. First of all, patients with substance use disorders, it doesn't matter whatever you are given. Most of the time, either you are not calculating the dose very well, and normally we go by using prolonged narcosis for them. That is to say that we go by chlorpromazine 200 milligram, right? BD, and then we give diazepam 20 milligram TDS. You are not supposed to wait until the patient wakes up. If it's chlorpromazine, if it's haloperidol, 10 milligram BD or 5 milligram BD. Definitely, the diazepam must always be 20 milligram IV, TID. You don't wait, right? 20 milligram IV. And the IV does not mean that you put it in, you dilute it in the normal saline. No, we want a quicker effect, right? The only thing is that you keep monitoring the blood pressure and then the pulse of the patient. But you do not give the opportunity for a patient to wake up first. So 20 milligram, if the patient is actually aggressive, the protocol is 20 milligram IV, 5 milligram haloperidol BD. Or you can go by chlorpromazine 150 milligram BD, haloperidol, diazepam 20 milligram TID if you see that the patient is actually aggressive. And do not put the IV diazepam in the normal saline. Okay. Secondly, it also depends on where you purchase the diazepam. We realize that given TID diazepam, you cannot do it outside. You cannot do that in the US. You can't do that in UK either. But our diazepam here is full of water. You don't really find the active ingredients much in each of the ampoules, and that is why it's also based on whether it is a British manufacturing company that did the drug. Most of the ones that we have in the system is coming from Pakistan, how do you call it? From India, Pakistan, and all that, and Nigeria. Come on, they are not quite effective. That's why we may end up giving like 20. Okay, so please do not back off by giving 20, just 20 starts. No, it should be repeated after 4 hours or 6 hours. You just repeat the 20 milligram of diazepam again. Okay, so make sure it is TID whilst you're monitoring. And if a person is a substance user, I'm telling you, he will just wake up. So that one, we just add the promethazine in between. Promethazine about 50 milligram or 100 milligram start, right, in between. And that can help the patient. After the first 24 hours, we should be achieving a therapeutic response with that particular patient, right? Okay. Now, people are asking questions around alcoholics have such challenge to respond to the effect of such of these medications and need careful administration. Godwin, you only need, in terms of what? Godwin, it depends on what you're talking about. Because if you have an alcoholic experiencing alcoholic hallucinosis, you still have to give chlorpromazine or preferably haloperidol, okay, 5 milligram, okay? At the withdrawal stage, they can hallucinate, so you can go ahead and give 5 milligram. Now, the diazepam you talk about in somebody who has alcohol withdrawal, okay, you can actually give diazepam 20 milligram BD. The patient will be fine. It is only contrary indicated in the patient that has intoxication. That is where you cannot give diazepam. Alcohol and diazepam work on the same receptor. And therefore, if the patient had withdrawn, giving diazepam to him is not even going to act as a sedative or hypnotic for him to sleep. He's rather going to experience the alcohol effect as if he's drinking alcohol, right? That's why we put them on Librium, or what we call the clothiazepate, which also is a benzodiazepam, right? Okay. Please, what should the nurse do when they mistakenly administer IV antipsychotic medications? Very good. So immediately you just set up IV normal saline, okay? IV normal saline, 1 liter. That will be okay. Can olanzapine and diazepam be given at the same time? Sister, you can give them at the same time because they work on different receptors. I always tell you that when you have two different drugs working on two different receptors, it can be given. Olanzapine works on dopamine receptor, diazepam, benzodiazepams, okay? So that is fine. But if you want to sedate a patient, when the patient cannot sleep, you don't prescribe diazepam for a patient to sleep. All is because of the dependency effect. Okay, so I'll tell you what you're supposed to do when someone says, I cannot sleep. Okay. If there are no more questions, then we'll continue. So we come to antidepressants, and of course, it's coming from depression and anxiety. That is why these medications came about. So you have Once you're given antidepressants, the mechanism is that it increases serotonin, okay, at the postsynaptic clefts, and then it can be transmitted. And also, some of the antidepressants can act as monoamide oxidase inhibitors because the enzyme necessary to process the monoamide oxidase inhibitors, sometimes they are too much. So the oxidase, which is an enzyme, when it's given in the form of antidepressant, they act as inhibitors to stop the reuptake of those serotonin, because enough serotonin needs to be processed from the synaptic clefts through the postsynaptic cleft to be transmitted. But when you have the oxidase, it inhibits the oxidase, less of it is being produced. So you need the inhibitors to stop the reuptake so that more of it can be transmitted through the postsynaptic cleft. Now, it also prevents so just as I told you, the reuptake of serotonin back to the exon terminal. Classification, we have three. We have monoamide oxidase inhibitors. We have got a tricyclic antidepressant, and then we have got selective serotonin reuptake inhibitors. So let's start with the monoamide oxidase inhibitors. Okay, so with the monoamide oxidase, it's just an enzyme, okay? And then as I told you, they inhibit the reuptake of the serotonin. Now let's look at what depression is all about so that you can understand it or you can appreciate it better. With depression, there is low level of serotonin, which means that we need to produce more serotonin, okay, to be pushed into the synaptic cleft from the presynaptic into the synapse to be processed through the postsynaptic cleft. However, when they get into the synaptic cleft, there's a tendency for them to be reabsorbed back into the exon terminal, which means that less of it will be pushed through the postsynaptic cleft, making the depression worse because it's limiting the amount of serotonin, okay, that needs to be transmitted. Please go back. Limiting the amount of that needs to be absorbed into the system. So the monoamide oxidase inhibitors are there to control the enzyme from doing that. And typical example is isocarbazate, okay? Not only isocarbazate, we have got phenylene. Phenylene is also part of it. Now, any patient who is on isocarbazate and then phenylene or isocarbazate, okay, isocarbazate, phenylene, these patients are not supposed to take any food that contains tyramine, okay, or tyramine. We are saying that because anytime you combine the two, you increase the effect of the tyramine, okay? Tyramine is the last product that is produced when you break down the monoamide systems, okay? The monoamide is supposed to be sufficient, that's supposed to be used. However, when you combine it, it increases the effect, and that can lead to hypertensive crisis, right? So I'm giving you typical foods like cheese, yogurt, meat, okay, and certain fermented foods. So any patient who is on isocarbazate or any of the monoamide oxidase medication is not supposed to take in cheese and yogurt, right? Otherwise, it will lead to what we call the hypertensive crisis, right? So that's the first type of antidepressant. We also have the second type, which is tricyclic antidepressant. Typical ones are the imipramine and then amitriptyline. I'm sure that you are used to amitriptyline. And amitriptyline is used to treat bedwetting, pain, especially neurogenic pain, okay, or neuropathy. And it's also used in panic attacks, right? And then the other one is selective serotonin reuptake inhibitors. That's another classification. And typical examples are fluoxetine, citalopram, and also sertraline. These are the newer medications that are in the system. So we don't prescribe the amitriptyline because amitriptyline can cause cardiac arrhythmias. So oftentimes we don't prescribe it. But you realize that when patients are unable to sleep, people normally prescribe amitriptyline for them. I don't remember the last time we made that prescription in my unit, right? It's because of the cardiac problems that it brings. So we don't normally prescribe it. But for kids that have bedwetting, imipramine and then amitriptyline actually works for them. right? But if you want to prescribe any good antidepressant, we go with the selective serotonin reuptake inhibitor, the SSRIs. And I've given you a typical examples like fluoxetine, sertraline, and then citalopram. They are the common ones that are currently prescribed to treat depression or anxiety, right? Okay, so let's move to the next. Then any questions before I move to the mood stabilizers? Okay, so someone's giving me a very long statement. It says, "Sir, a client was managed for alcohol withdrawal with both visual and auditory hallucination. The day staff administered diazepam and midazolam to calm the aggressiveness, but was nil. It means that it didn't respond well. At night, the review was done by the night doctor, and IV ketamine 100 milligrams was administered. But clients became more agitated, right, or aggressive. Additionally, the dose of 150 milligram in divided doses were administered with physical restraint too, but the client was able to tear free from like that. So he was mechanically restrained, but it was not successful, right? And was observed to be sleeping after 6 a.m. Please, what could have been done better? I like this kind of question. So anytime a patient is actually withdrawing from alcohol, typical symptoms you are going to see is both the visual and auditory hallucination together with tremors. Some people can also end up having seizures, okay? They can have seizures in addition. Apart from that, they can sweat, they can have delirium where they become disoriented, confused, not focusing. Their visual hallucination comes in the form of seeing things like lizard moving over the curtain, or in the polythene bag, they'll be seeing ants moving in and out, okay? So these are the typical signs you're going to see for someone who's withdrawing from alcohol. Now, what you presented is what we call the alcohol hallucinosis, which is in the first stage. So, alcohol hallucinosis, what you just need to do is simply go for low dose of antipsychotics. So, you start with haloperidol 5 milligrams start, right? Because at that point, the patient will not be willing to take tablets. So, you go with haloperidol 5 milligrams start. Also, depending on the weight, you can do 10 milligrams start. Okay, don't do coprimazine, do haloperidol 5 milligrams start. Plus, you can just add the diazepam. The diazepam, you should have gone in for 20, okay? 20 milligrams start. Secondly, you guys needed to do a detoxification straight away. You should have done perintrovite 1 and 2, okay? You should have done 2 doses within 24 hours. And the diazepam should have been TDS for the patient. The diazepam should have been TDS for the patient, whilst the haloperidol going for 5 milligram BD, and that patient would have been fine, right? So next time, kindly focus on that. Sir, please, I sometimes have insomnia and normally take amitriptyline because I can't sleep. Is it advisable? This is Stella. Stella, interesting. I don't know whether you want me to answer this on this particular platform or you want me to answer it privately. Please, is taking amitriptyline for migraine good? Okay. Sir, please, why diazepam should not be diluted? Sweetie, the 20 milligram of diazepam in normal saline is like you are splitting the effect. And we want an immediate response. If it's well concentrated, when you give it, the effect takes place. Compared to giving it, putting in the normal saline, it's going to take time. I mean, think about how long it takes normal saline to get emptied, right? So, come on, you're not going to have an immediate effect. Please, can the use of amitriptyline over a long period cause heart condition? That's what I told her. I said, it leads to cardiac arrhythmias. So it's not advisable. That you are denied of, oh my God. Sir, please, sometimes clothiazepate is added. Yes, I told you clothiazepate is a benzodiazepam. Okay, so instead of prescribing diazepam as a tablet for someone with alcohol, we give them Librium, which is the same as clothiazepate. We go by 20 milligram BD, depending on the withdrawal symptoms or the dependency or the addiction, okay, depending on the history. but normally we go with 20 milligram BD first, if the patient is able to swallow. Okay. Now he's actually doing the is that what he's doing? Okay, he's doing it. Thank you. What about the ketamine? I do not subscribe to ketamine. Ketamine can be used to treat depression, but I don't know why people normally use it when they are in agitated state. At ER, some of our emergency doctors used to do that, but I don't know why they do that, because I've just realized that it's not actually used. It has its effects itself. Will not achieve a good effect, and moreover, to the side effect is going to lead to something else. Because think about the use of ketamine, why it was prescribed. So they are using it as an off-label. Okay, so it's not the best medications or choice of medications to make. Someone said, "What of bedwetting adults? Is the amitriptyline safe and can it cure it?" No, please. The essence of giving amitriptyline or imipramine, we are also using as an off-label effect. Off-label in the sense that imipramine and amitriptyline can cause urine retention, right? That's a side effect. So we are using it as a side effect. And remember, there are so many causes of, you have to delve into the cause of bedwetting in an adult. Okay? Is it prostate that has started? That is why. Okay, so you need to have a neurological history of the patient. That is very, very important. Or is it coming from a UTI? Okay, so we don't just, or there's a trauma to the bladder. So you're only using in adults, if you are prescribing amitriptyline for bedwetting, it's just a temporal thing, but you just need to investigate further to know why that patient will put on, why he's having the bedwet. Okay. Yes, please. When I say that amitriptyline can cause cardiac arrhythmia, it doesn't mean it's immediate. Okay, I'm not talking about it being immediate, right? Can we combine any of the antidepressant together and prescribe? No, I've not seen it done. Kwame Ampon, I've not seen that done. Either you increase the dose or you switch. So when you see someone on two antidepressants, it means that they are doing what we call cross-tapering. It means that they want the other one to reduce and then they increase that effect, and then later they take off one. But we do not prescribe two antidepressants together, right? And the diazepam is done there. Okay, fine. Don't do diazepam as a PRN for a patient with alcohol withdrawal. Do it as a real treatment regimen. Okay. So please, so which medication is best for insomnia? So Juliana, right? Juliana, what happened is that I cannot say that which medication is good for insomnia, because the medications we give you, they are temporal. Okay, is to allow you to have rest temporarily. We are taking you out of the acute phase of insomnia. And remember, insomnia, we have got 3 types. Is it initial insomnia? Is it maintenance problem? Okay, or early wake? So, or short sleeps. I mean, we just need to investigate that. Secondly, what is bringing about the sleep problems? Right? So we need to investigate first. But diazepam is not actually good for sleep. Normally, when you cannot sleep, we can go by prescribing citalopram for you or sertraline, or we can even go by clozapam. Clozapam is one of the newest benzodiazepam that can help with that can give a hypnotic effect. It comes to 0.5 milligram. It's also very good. We can also prescribe melatonin. Melatonin is also very effective when it comes to sleep. Okay. So thank you, sir. Please, even yesterday I had to take amitriptyline before sleeping. Stella, are you married?
No, sir.
You're not. Okay. Do you have any children?
Please, I have one.
Okay. Do you live with a kid?
Yes, please.
Okay. So see me and let's discuss why you cannot sleep. Okay.
Okay, sir. Thank you.
What's happening later? Okay. So for insomnia, some need to switch off their phone. They will be sleeping. Oh my God. Kwame, okay, I think I've answered most of the questions for you. Yeah, I think I've done well to do that. Okay. Okay, so let's come to the mood stabilizer, also known as the anti-manic medication. So most of the time, patient come in with bipolar. Most of you have heard bipolar. I will teach you on bipolar, but you heard of it before. Formerly known as the manic depressive psychosis. Okay, where you have manic phase and then later the patient can manifest depressive phase in the course of the. So it's bipolar. Either you have it as monopolar, unipolar, that is only mania alone, or you can have it as depression, right? In order to control the mood of the patient, we have got a gold standard for managing mania, and that is the lithium carbonate. There are also other medications that can help with mood stabilizers, that can act as mood stabilizers. Olanzapine, which is a second generation antipsychotic, can act as a mood stabilizer. Secondly, the anti-seizure medications can also act as a mood stabilizer. So you have sodium valproate, you can have lamotrigine, okay? These two medications can serve as mood stabilizers, right? So they can be prescribed, and then carbamazepine can also be a mood stabilizer. And all those medications can also be used, okay, in treating the patient with bipolar. But the gold standard for treating bipolar, especially with someone with manic symptoms, is to go in for lithium carbonate. So you can see that lithium carbonate is actually used to treat patients with bipolar and then at the same time schizoaffective, which means that schizoaffective means that it can be schizomania or schizodepression, right? So, yeah. Now, the only thing is that when you take lithium carbonate, okay, it can normally people that you hear the patient say that it has a metallic taste, and then the side effect is it can lead to tremors. Now, anyone on lithium must be monitored therapeutically. So normally, after 2 weeks, okay, we have to do lab work to see whether the person is in therapeutic range. We don't want the lithium to elevate because it can lead to lithium toxicity, okay, which can bring about tremors and mental changes. So this is the therapeutic range. Thank you. Okay, so with a therapeutic range, it starts from 0.2 to 2 mml, okay? Now, any patient who is on lithium carbonate has to drink a lot of water in order to help with the clearance, okay, by the liver, so that clearance by the kidney or by the renal function. So it's very important that while it's being detoxified, the metabolized left is being cleared out by the kidney, right? So this is what you actually need to know. Let's go to the next. I'm very sure that. Okay, so the next one is the anticholinergic. I'm sure that you have come across this, what you guys call attain and then cogentin. So basically, they prevent the extrapyramidal side effect that we mentioned, like akathisia, neuroleptic malignant syndrome, acute dystonic reaction, Parkinson's, Parkinsonism, tardive dyskinesia. Okay, all those things. And then tardive dyskinesia it can't help with tardive dyskinesia. It's the only thing that cannot help with tardive dyskinesia because that one is irreversible. But the rest, we can put the patient on attain and then cogentin. Remember, attain comes in 5 milligram and then cogentin comes in 2 milligram. In Ghana, currently, we do not have the IM injection or the injectable form, but outside the country, that is part in UK, Australia, I mean, when you go outside, you may have cogentin being given as in the form of injectable, right? So anytime you realize that anytime we put patients on haloperidol, we give attain as a PRN because we don't want them to develop the extrapyramidal side effects. So basically, these are some of the psychotropic medications we can discuss. Let's go to the next one. Okay, so this one is for you to probably read on anxiolytic anti-seizure medication, which I've already mentioned, lamotrigine, sodium valproate, etoposide, carbamazepine, they're all anti-seizures. And then how they work is that they only increase the GABA effect, okay, so that it can arrest the seizures. Anxiolytics are also part of some antidepressants serve as anxiolytics. Sedative and hypnotics are normally the benzodiazepam. The difference is that sedatives are for relaxing the muscles, okay? While the hypnotics indicates sleep. So when we say that you have sedated a patient, it doesn't mean that the patient is asleep. We are saying that you have rather calmed the patient. So for example, if you use the diazepam and you serve the diazepam as 10 milligram, it may bring a sedative effect, but it may not pose a hypnotic effect. By hypnotic means that it's a sleep state. So the more you increase the dose of the medication, it can lead to what? Sleep effect, which is the hypnotics. So Big Girl, I want you to read further on that. Any question, because you are moving to the next.
So, sir, when client come with problems of primary insomnia or secondary insomnia, usually, as you said, amitriptyline is not good. Diazepam too. So, should we always go in for the hypnotics?
Please come again. Sorry, I missed the line.
I mean, with insomnia, in your definition, you said amitriptyline is dangerous in insomnia.
Please talk like. Okay, so when I say something, it's not absolute. What I'm trying to say is that I said it has been by clinical trials, they have realized that patients who are put on amitriptyline, after some time, they develop cardiac arrhythmias, and so it's not suitable, okay, to be used for a long period. And so people don't really go out for it. That doesn't mean that when somebody has neuropathy and then migraine and all that, it's not prescribed. It is, but actually they do the EEG to monitor. Okay, so if you want someone to sleep, first of all, don't be in a hurry to make any prescription. Let's always go back to the table and ask the person further questions. Why can't you sleep? How long is it? Is it coming from stress? Is that as a result of overthinking because you're having a breakup with someone, you lost your book, or you have? So just explore to know why somebody cannot sleep. And I told you that the medications are not there to correct why you cannot sleep. Please always go back and ask yourself the why. The cause itself need to be dealt with. The medication that we are given is to help you because physiologically you actually need to sleep. So in acute way, we are trying to handle it temporarily to help you to sleep for some time. But we have to always go back and trace why you are having that particular problem. Okay, and I'm giving you typical examples of medication that can actually help us sleep. I mentioned medications like sertraline, citalopram. You can also go by taking this medication, clozapam. Clozapam is 0.5. You can also give 0.25 or 1 milligram, right? You cannot. And then melatonin. All those medications going to help you to sleep, right? Do you get me?
Yes, sir. Thank you.
Okay, Sammy, thank you. Now let's get back to look at therapeutics. So with therapeutics, we are looking at other therapies apart from the pharmacological approach. What else do we use to treat patients with having psychotic symptoms or neurotic symptoms? But this one is for psychotic symptoms. So let me introduce you to electroconvulsive therapy, also known as electroplexy, right? Next. Okay. So ECT, as we know, is shock therapy. It was introduced by Lucio Baini and Hugo Saletti in 1937. The mechanism is that it's increasing the threshold of the grand mal seizures. And by increasing it, rather, it stimulates, the neurochemicals and it causes it to be balanced. Okay. Now we are aware that before they introduce the grand mal seizures, they induce what they call an electrical shock through the person. But these electrical voltages are calculated before they introduce it. And we know that electrodes are placed at the temples of the patients before the shock comes in. Okay, and the shock is given between the first 5 to 10 seconds, and then the patient is thrown into grand mal seizures for some time, right? Okay. Next. Supporting theories. So the focus is on the neurotransmitters, as I told you. We want the neurotransmitters balanced, particularly even the dopamine, okay? But it helps with other neurotransmitters to be balanced. They believe that once you shake it, you shake the brain, it helps them to be in order. And then the maximum is about 6 shots. Okay, people have to take 6 shots to recover. So it works like anticonvulsant, it can work like antipsychotic, it can work like antidepressants at the same time. So those are the supporting theories about it. But even the full mechanism of ECT is not yet understood, but we know that it brings about good results for patients. So let's look at the indications. So this is a typical ECT machine. Okay, when you go to Confanochi, you're going to see this. So you can see the monitor, and then you can see the electrodes, right? Okay, so in terms of the application, we have got the unilateral, that is putting on one side of the brain. So either you put it at the forehead, people put it at the temporal lobe area, that is superior to that of the ear, or posterior of the ear, around the temporal lobe area. Okay, so when it's placed at one side, it's known as unilateral. When it's placed at both, it's bilateral. Okay, and that will be, but commonly is done as bilateral. Let's go to the next one. So this is a typical example of ECT being done for someone. Now, all what you can you are seeing on is to monitor the brain waves. So in the US, they have those ones monitoring the brain waves of the patient at the same time. And then you have the electrodes being placed at the temples. So once it's induced through the temples, immediately you see the person being thrown into the grand mal seizures, right? And the person starts shaking. And so you can see the tongue depressant, okay, depressor, okay, in the mouth of the patient, because you want to make sure that the patient don't bite their own tongue. So you just do that. And sometimes anesthesia is given. Let's go. I'll give you something. I'll tell you something. Okay. So the mode of application, we have got a straight and then a modified. So the straight is given without anesthesia. Okay. By anesthesia, they can introduce low dose of diazepam or any of their anesthetic agents that they serve. So with straight, they don't give any anesthesia. They just administer or induce the seizures just like that. But when a modified one came in, they give the anesthesia in order to prevent too much shaking and too much break of the twitch to the muscles and that to the bones. Okay, so the modified one is the one that is recently used. So anytime we are doing ECT at cath, we always need to bring in the anesthetist to come in to help us as if we are doing that surgery. So it gives a muscle relaxant to help the patient at the same time. So it doesn't really go into too much of the grand mal seizures. Okay. So what are the indications? Under which circumstance can we say that this person needs ECT? So bipolar mania, that is not responding to medications, okay? Schizoaffective, that is not responding to medications. Major depressive psychosis with suicidal tendencies, okay? Depression with suicidal tendencies. Postpartum psychosis that is not responding to medications. And then also in schizophrenia like paranoid, delusional, and catatonic schizophrenia. Under these conditions, we prescribe ECT to be done for these group of people. I mentioned that when the patient is not responding to a pharmacological treatment. And after ECT, you can still go ahead and prescribe medications alongside, right? The patient needs 6 to 12 shots, okay? So that is how we go by the prescription. Okay, next. Contraindication. Under what circumstances can't we do ECT? So number one, when a person has cardiac problems, so you have angina, you have myocardial infarction, please go back. Okay, no, go back. You go back. Let's talk about the contraindications. Then we come back. Okay, so stroke, brain tumor, recent fracture and dislocation, TB and asthma because of the respiration. Okay, and then severe HPT, congenital heart problems, people who have blood vessel inflammation conditions. So these are the contraindications, right? Now let's go to the preparation, the nursing preparation quickly. Okay, so for us to prepare a patient for ECT, unfortunately, I've even seen a patient who underwent ECT and then died because there was no anesthetic nurse around to help with the ECT being done. And it was pathetic that someone will undergo ECT and die in the process. I think he aspirated and then died in the course of that. So following nursing protocol for surgery, just like you prepare any patient for surgery, like the day before, 24 hours or 12 hours before the surgery, 12 hours before the surgery, patient is supposed to empty the bowels, is not supposed to eat, right? So he'll be on nil per ox for some time, right? And also maintain personal hygiene, get everything he needs, okay? Vital signs being checked, and consent form being filled by the family relative, okay? They're also informed of the side effects of it. So education and consent form is actually done by the relative because the patient himself doesn't have insight. So you need someone to actually consent before we can proceed with the ECT. We also rule out contraindications because you have to do labs, okay, and take a history about cardiovascular problems and tumors and recent fractures and respiratory problems and all that before you can do that. So you need 5 to 10 seconds of shock. The total is 6 times to 12 times, depending on that. Post-op care also follow the same nursing protocol. When you bring the patient back, monitoring of the vital signs, okay, ensuring that patients are taking in something. So you start with fluid diets first before you continue with, after 48 hours, the patient can resume full solid food. Okay. Now, what are the side effects? So after ECT, patients complain of headaches, which is very common. And then sometimes they even talk about, some people complain about bodily pains as if they have been beaten and they are tired. There's also confusion with the patient, then a loss of memory, injuries, and then there may be possible fractures, right? But it's not quite common. So these are the side effects. Next. Okay. Any question before I move to the psychological therapies? Any question?
Yes, sir. Sir,
Kindly go ahead.
please. Is the loss of memory, is it long term or short term?
Oh, it's very short term. So it's temporal.
Okay.
Yeah, thank you. Temporal. Okay. Yeah. Any other questions before we go to the next? Okay, so let's go to psychological therapies. So we have got CBT. Kindly go back. CBT, which is cognitive behavioral therapy, psychotherapy, counseling, mindfulness, and then we have got eye movement therapy. So let's look at that quickly. So in the treating of patients, not only pharmacological approach, but we also use psychotherapeutic approach. Okay. So these are the list of some of them. There are other ones that you can use, but we are just restricting ourselves to this. When you have time, you read further on the other psychological therapy. So let's look at what CBT is. CBT is cognitive behavioral therapy. It's looking at how we think, okay? And they believe that how you think, that means your cognition can affect your behavior. Whatever you think about makes you act. Your thinking can change your emotions, and then it puts you into the way you act. Therefore, CBT is believing that if we go back to go and look at your thought patterns, okay, how you are thinking, if we can change that, it's going to change your feelings and your behavior. So anyone who's having negative thoughts, it's manifested in his behavior. Okay. So if you are afraid because you have something that's going to happen to you, those are negative thoughts. That is going to prevent you from coming out or from getting engaged socially. Okay. So CBT believes that if we check your thought patterns, and so they identify the thought pattern, where the thoughts are coming from, how it is being framed, and your interpretation of those thoughts. Once we can understand that, and the patient can also have insight into his own thoughts, we can go back to reverse or replace those thoughts with other thoughts that are more beneficial. Okay, that's why some of you say that you are more pessimistic, you are more optimistic now, or you say positive thinking, because we know that if the thoughts become positive, it manifests in your own behavior, right? Okay, let's go to the next. But please note that the therapies are not given one day. Okay, you have to come. It comes in sessions. So CBT and then psychotherapy can go about 12 sessions before you are okay. All right. So let's look at psychodynamic therapy. So this one looks at that there's a concept that repressed emotion can affect people in life. Now, this one came from Sigmund Freud and his colleagues. Sigmund liked talking about the unconscious thoughts, saying that the things that you have repressed in your mind can manifest or can affect you. So, for example, wishes, desires, things that you want to do, or things that are traumatic to you, you have repressed them and you don't want to talk about them. There's a difference between repression and suppression. Repression becomes unconscious, it goes into your subconscious mind, into the unconscious mind. But when it comes to suppression, it's intentional, it's actually suppressed, but it's in the conscious mind. And sometimes people are not even aware of the things they buried deeply in their unconscious mind. So the psychodynamic theory feeds on the unconsciousness or the unconscious thoughts. So they help the patient go back into time. And that is why you can see the lady lying in the couch with the eye closed. Okay, and the therapy is going to take him back into his childhood to explore buried thoughts. So it can be in the form of a rape, can be a form of being sexually abused or physically abused, or something else happened to that person. Because we believe that things that happen to you in your childhood, especially in the first 12 years of life, it informs your behavior now. It can actually forms your personality. So by taking you back into time, you are able to remember and start recalling. Okay? And so that is what the therapist is trying to. So by exploring unconscious thought, past experiences, and unresolved conflicts, we uncover the reason for the behavior. The person adapts more positive behavior with meaning. It means that we will not go and talk about the fact that your mother didn't abuse you, didn't beat you, or you were not raped. Rather, we will help you to understand why it happened and the meaning you are making out of it. So it's called interpretation. And the therapist is going to help you to form a different interpretation about the event. Okay? So that you change the narrative. Right. Okay. Next one. Okay, so we have got the eye movement desensitization and reprocessing. This particular therapy is used for people who are traumatized. Okay, so people who go for war, like veterans, okay, soldiers who come from the Iraq war, suffered from PTSD, and then the eye rapid desensitization and reprocessing was used as a means of helping them go back into time, okay, and then help them to balance their emotions. So with the eye movement rapid therapy, they have certain cardiac monitoring system, okay, that detects slight changes in your body. and the therapists takes you back into when you were at the war, whatever happened, trying to help you have a flashback and teaches you how to take in deep breath. It's like a biofeedback mechanism, but this one they use the eye, okay? Because your eye will determine whether you cannot. The eye does not lie. It's just like somebody having a bad dream. You see it on the eye. So they teach them how they can handle those emotions, right? So that is why you have an example that a person with PTSD follows the therapist guide eye movement while recalling a traumatic event, which reduces its emotional impact. I've never seen anyone using this before in Ghana, but I don't know. But I'm sure that there are some psychologists who can do that. Let's go to the next one. Yeah. Now, this is the meditation, right? So it's a therapeutic approach that focuses on cultivating mindfulness, which involves paying attention to the present moment in a non-judgmental way. So with mindfulness, we want you to be mindful about what is happening to you now. And normally start with being present by responding to your physiological feelings. So for example, wherever you are seated, I want somebody to come online, put your video on. If you are sitting somewhere, just put your video on. I want to use you as an example. One single person. Let me take you through. If you are sitting somewhere that is safe, like, come on, put it on. Let me see you. I want a male to do that. Kwame. Kwame Ampong.
Hello, sir.
Kwame, are you home?
Yeah, but I'm not safe right now, sir. I can't go on video, please.
Okay, I need someone to go on a video. If I should have said accidental. Very good. No, let me take Ima. Derry, you can go off. Ima, position your camera far away from you. Okay, so can you hear me?
Yes, sir.
Very good. I don't want you to touch the camera any longer.
Okay.
Now I want you to sit upright. Okay. Now, sorry, I can't see your feet. I wish you are sitting. I need to see your feet first before you go back. Let me see your feet, the way you are seated.
My feet.
Yeah, I need to see how you are seated. So just turn the camera towards your knee and your feet, and then go back. Okay, so put your two legs. Very good. So put your two legs together and sit upright. Very good. And put the two. So now leave the camera. I want to look at your face at the same time. Now leave
okay.
No, leave the camera now. It's okay. That's okay. Now, whilst your feet are together, place your hand on your thighs and relax. So what is going to happen is that I'm going to ask you typical questions, okay? Now, I want you to tell me where you feel pressure in your body, starting from your head. So where do you feel pressure? If you're supposed to think about coming from your head, going down to your feet, where do you feel the pressure?
I feel the pressure at my back.
Okay, that's one. Where else do you feel the pressure?
My neck.
Very good. Where else do you feel the pressure? Where?
Because I kept my hands on my knees, I feel some pressure at my shoulder.
Very good. Where else do you feel the pressure?
My chest.
Your chest.
Yeah.
Where else do you feel the pressure? So let me tell you where you feel the pressures. You feel it around your neck. You feel it around your butt. You feel it at your sacral region and then your spine. You also feel it at your ankles and then your feet. Okay. So what I was trying to do, okay, is to help you move your mind into your body instead of focusing on whatever is going around you. So you realize that the moment I started asking you those questions, right, you started directing your mind into your body to be more sensitive to what is happening. Now, all this while, these pressures have been there, but you're not paying attention to them. Okay, so what mindfulness does is that at the beginning, some people start with this. They try to get more connected to what is happening in their body first, because it helps you to direct your mind into your body instead of what is around. So you realize that the key word there is being present, meaning being here, not thinking about what is going outside you, but right now what's happening in you. The same thing as if I ask you to close your eyes and maybe I take you through a scene and I ask you that what happened yesterday, what happened, and you realize that you start imagining whatever happened, right? A typical one is that when you wake up in the morning, what was the first thing you did?
So I brushed my teeth after that. I took my breakfast.
No, when you got out of the bed, did you turn through the right or the left?
Well, I can't remember.
Very good. And then what was the first sound you heard when you got up?
The first sound was my alarm.
Your name?
My alarm, my phone alarm.
Okay. And then when you got up, what did you do first? Did you switch on the light or you went to the bathroom?
I turned off the alarm, then I went straight to the bathroom.
Okay. Then in the bathroom, when you came out, what did you do before you started studying?
I took my breakfast.
Don't tell me you went to poo-poo. Don't tell me you went to poo-poo. No. So what is going to happen is that what I'm trying to do is to take you back. Okay. So what happened is that the mindfulness is a very good exercise that helps you to be present instead of thinking about worries. Okay. Like what is going to happen? What is going to happen because this man is chasing my girl, because this thing is going to get wrong. No. It brings you back into time. Okay, so being present. Now, some people do it by, putting their feet together. So, Emma, thank you. You can go off. Putting their two legs together, as you say, cross, and then they put their the index finger and then the middle finger and then the thumbs together. They do that because, according to the theory, it helps with balance straight into the heart and to the mind. So it draws, like when you draw a pyramid, the forehead becomes the apex, and then the two arms serve as the two borders, okay, to draw a triangle. So it puts you in that state to be balanced with the universe, according to them. And we are saying that when you are meditating, you become non-judgmental. Depending on the image you want to have in your mind, you pick that image and then you work with it. Wow. It's also a period for self-compassion, and then it comes with. So mindfulness goes together with meditations, okay? But it simply means that being present at the moment. And that helps you to channel more energy into what is happening right now than to be having worried thoughts. Okay, so that is that. Let's go to the next one. I'm sure I'm even done. Okay, so there's a difference between counseling and then psychotherapy. Okay, so counseling is just a short term, and then psychotherapy is a long term that we do. Counseling focuses on supporting the patient to perform day-to-day activities in a normal and efficient manner. But when it comes to psychotherapy, it's uncover the foundations of the problem and address it in the most effective manner. So we are more after what brought about the problem and diving deeper. In counseling, we address issues in a less in-depth form, whilst the other is the opposite. Counseling also deal with patients who are fit enough to think rationally and find solutions to their problem by themselves. So most of you may need counseling. So when you are coming for direction, you are coming for maybe you just need an insight into what you can do as master's program. You need a guide on that, or maybe you have been facing a particular problem and you want to be counseled. Counsel means that we want to guide you to make a good choice. But psychotherapy goes deeper. It involves individuals who are dependent on the psychotherapist because at that point, they are not able to have what it takes to make those decisions. Okay, so we are helping you to gain control over your own personality, your mind, your emotions, and your behavior. So these are the basic differences, right? Let's go to the next one. Okay, so this is a typical counseling session. It's one of the most beautiful part of therapy when you have a client sitting right in front of you and you are having a chat. It's very beautiful. I think those of you who actually know that I practice in tech, when you come to room 6, you know that I do it beautifully there, right? Okay, so ladies and gentlemen, we come to the end of the lecture. So today we studied on, well, we're looking at psychotropic medications, particularly we look at the classification. We came to look at antipsychotic medication. We mentioned some of the antipsychotic medication, first generation, second generation, their function, extrapyramidal side effects, the mechanism, the indications, okay? We mentioned long acting and short acting. We mentioned the second generation and then their adverse side effects, including the extrapyramidal side effect of the first generation. We came to antidepressant, mentioning the three different classifications: monoamide oxidase inhibitors, tricyclic antidepressants. We also look at it in terms of serotonin, selective serotonin inhibitors. We also give indications. People asked a lot of questions, right? That came up. We also look at anticholinergics, okay, and why they are prescribed. We have also looked at anti-manic medications, right? And then I further went by discussing with you sedative, hypnotics, anxiolytics, which are still sedative hypnotic, and then anti-psychotic, anti-seizure medication. People ask questions around alcohol, and then also emergency treatments, right? We also came to look at psychotherapy. We start with other treatment like ECT, and we gave the mechanism, indications, the number of times, the contraindications, and how people are prepared for ECT. And then the last one we came to look at has got to do with the psychotherapeutic strategies or approaches. We have looked at counseling, psychotherapy, rapid eye movement, or we also look at mindfulness, and then we also look at CBT. Any questions? Someone's asking how CBT is. CBT is just done like the way you do counseling. It's still done in the same way. The difference is that CBT is using a different approach. They are looking at the way you think. You see that the difference is the approach and the philosophy of, or the kind of theory the therapist has adopted. So we can approach things in different ways, but somebody choose to do CBT because that particular person wants to look at the way you are thinking. Okay? And there are sessions. You don't just have one single one and then you're done, right? There are sessions. And any question? Any question, please? Now, I want to ask you a question. So there's this question that says that a patient was put on D2 blocker. Okay. Now, after 1 month, the patient started experiencing lactation and also experiencing gynecomastia. Why is the patient experiencing gynecomastia and then also having lactation as a problem? How will you explain it? Did you hear me?
Sir, please kindly repeat the question.
A patient was seen to have developed gynecomastia and also lactating. Is a male. So the question we are beginning to ask, sorry, is a female. No, it's a male. It's a male. It's a male. Is developing gynecomastia. Okay, just imagine both sexes, right? Gynecomastia is seen more in males, but lactation is seen in females. So let's just imagine that a patient who is a female, okay, was lactating at the same time, had amenorrhea as a result of having been put on clopomazine. The question is that why? So I need someone to answer. 28-year-old is on clopomazine, later develops amenorrhea, and then was also seen to lactate. What is the problem with this patient?
Sir, the dopamine normally inhibits prolactin.
Let me hear you.
Dopamine normally inhibits the release of prolactin.
It's rather increases prolactin stimulation rather. It doesn't inhibit it. It's rather lead to hyperprolactinemia. The mucus excretion. So that is why. It's rather the opposite. Okay?
Okay.
Okay. So thank you very much for showing up. I'll see you next week.
Yes, you